dorsum of hand, that is posterior aspect of hand. Here we are checking whether there is any local raise of temperature is there or not. Now let's check for tenderness. First we will rub our both the palms. Then we will press over the chest slightly to see whether the patient is having pain. If at all the patient is having pain, that means tenderness is present.
Now position of trachea. As I said, trachea is normally situated centrally or slightly on right side. We will see in video how to palpate for it.
To palpate for position of trachea, we will use 3 fingers. One is index, then middle finger and ring finger. So this index finger and ring finger, this you have to place on sternoclavicular joint, and middle finger is the one which you will use to feel for tracheal rings. So let's see how we will do. So this is index and ring finger. So this is a sternoclavicular joint. So this I am keeping here index finger, and here I am keeping ring finger. Now with the help of this middle finger, I will try to feel for tracheal rings. Okay, so this is how we check for position of trachea. Now another method, that is you can use index finger and middle finger. Index finger you have to place between sternocleidomastoid muscle and trachea. So if it, and this middle finger you have to place between the another sternocleidomastoid and trachea, and if it is easily insertable, then the trachea is in centrally. But if it is not easily insertable in any side, either on left or right side, that means the trachea has been shifted to that particular side.
Now, what are the causes of shifting of trachea? The causes of shifting of trachea on the same side or on opposite side. Okay, when the trachea has been shifted to the same side, that means there can be the lung fibrosis or collapse. And if it has been shifted to the opposite side, that means there is maybe pleural effusion, pneumothorax or lung tumor. Now, how do you understand by shifting on the same side or opposite side? So, for example, if the trachea of the patient is shifted to the left side. So, when the trachea has been shifted to the left side, we have to think that either on the left side there is lung fibrosis or lung collapse. So, because of that the trachea is pulled to that particular side. Means left side lung fibrosis or collapse is there. So, that will be pulling the trachea. Okay. So, means the same side means the pathology is in the left side and trachea is shifted to the left side. Means same side of the pathology the trachea has been shifted, means the trachea is pulled. But now for example, on right side there is pleural effusion, pneumothorax or tumor. So what happens at that time, the trachea will be shifted to the left side because there is massive pleural effusion on right side or pneumothorax, and that because of the enlargement of the lung, the trachea will be shifted to the opposite side. Okay. In the next slide, we will see apex bit. So as I said, it is situated in the left fifth intercostal space, half an inch medial to the mid-clavicular line. I'll show you in the video how to check for apex bit. But again, apex bit also same like trachea when there is shifting of mediastinum. Also, there is change in position of apex bit. Okay.
Now let's palpate for apex bit. Now first we have to use our palm. Okay, so usually apex bit is situated normally in left fifth intercostal space, half an inch medial to the mid clavicular line. This is mid clavicular line. So half an inch medial to the mid clavicular line in left fifth intercostal space. So first we have to use our palm to feel for apex bit. Then you have to locate it by ulnar border, then with the finger. Now we palpate for apex view. If at all it has been shifted either slightly on left side or right, so whenever there is mediastinum has been shifted, that time the location also gets shifted.
Now next, chest measurement. So under this, we will measure for the transverse diameter, AP diameter and full chest diameter. Transverse diameter is more normally as compared to AP diameter. Okay. So now how to check for it? We will see in video. Okay.
Okay. So chest measurement, we will measure transverse diameter, AP diameter and full chest diameter. So for the AP diameter, we have to place cardboards on front of the chest and back of the chest, right? And then we will measure a distance between these two. Okay. So this is 26. Okay. Now we will check for transverse diameter. So that is, we will keep between these two, okay, and then we will check a distance between these two, that has come 33. So transverse diameter has come more than AP diameter. Okay. No, sorry. So it is 96. Now ask the person to deep inspiration. Now it is 99. Okay. Sorry.
Let's see the video.
Now let's see for chest movements. So we will check for anteriorly, then posterior and apices. So let's see for anterior. How I have to keep the thumb and fingers, that is, the fingers should be parallel to the ribs and thumb should be centrally. Now see, this is. Now I will ask the subject to inspire, then expire, inspire, then expire. Now little bit down we will do inspire, expire, inspire, expire, inspire, expire, inspire, expire. This is anterior chest movement. On posterior side. So again, finger should be parallel to the ribs, thumb should be in the centrally. Now ask the subject to inspire, then expire, inspire, expire. Now on apices, ask the subject to inspire, expire, inspire, expire.
Then what are the asymmetrical chest movement? See, by doing chest movement, we get to know that whether the movement of the chest is equally on both the side or not, right? So when it is not moving equally on both the side, means one side of the chest movement is less as compared to other side, that means your one side of the thumb will move less as compared to the opposite side of thumb, right? So that time we get to know that the chest movement is not symmetrical on both the side, rather it is asymmetrical. So causes could be maybe the side of the thumb which is moving less, that side maybe the pleural effusion is there, pneumothorax is there, emphysema might be there, fibrosis is there, or lung has collapsed. Okay, so these are the causes. Now tactile vocal fremitus.
So in tactile vocal fremitus. So what is tactile vocal fremitus? That is a vibration which has been transmitted to the chest wall from the vocal cord, and that has been felt by the ulnar border of hand. Okay. So how do we check? We have to place the ulnar border on the areas of the chest. Okay. So let's see. During this, we have to ask a person to speak 1, 2, 3, 1, 2, 3 continuously. Okay. 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Then on axillary part.
1, 2, 3.
Then here.
1, 2, 3.
Then again here.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay. So I am feeling equally on both the side of chest. Okay. Vibrations are felt equally on both the side of chest. Now on posteriorly.
एक करीबी है. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
So what are the causes where tactile vocal fremitus increases? It is in lobar pneumonia and tuberculosis, whether it decreases in bronchial obstruction, pleural effusion, pneumothorax, collapse, thickened pleura, lung collapse and thickened pleura. Now percussion. So percussion is done for knowing lung border, and also based on percussion note we get to know about differential diagnosis. Okay. Like if it is resonant, then it is normal. If it is hyperresonant, then it is a different condition. If it is dull, then it is a pleural effusion. In that way we come to a differential diagnosis. So where we will do on anterior test, we will do on mid-clavicular line, then on lateral side on mid-axillary line, and posteriorly on scapular line we will do percussion. Now let's see percussion. Percussion is already taught to you during history taking in general examination class, that how to do percussion. So let's see video once again how to do percussion.
Let's see percussion. So in percussion we are using fingers. One is pleximeter and another one is flexor. So what is flexor? So that is the finger which we are using to give impact, and pleximeter is a finger on which we are giving impact. Okay. So by doing the percussion we can get an idea about the borders of lung. So percussion we will do anteriorly in mid-clavicular line, then in mid-axillary line, and then on posteriorly mid-scapular line we will do percussion. Okay. And then for the apex of the lung we will also do percussion. When we are doing percussion in normal subject, the sound is resonant, but when the sound changes, when it becomes hyper resonant or it becomes dull, okay, so that time we have to think that some pathology has been involved. Okay. So let's see. This is how I have to keep a finger. Only the middle phalanx of my finger should touch to the chest. Okay, and I will give now impact with the plexus. Okay, so we are doing in mid clavicular line now. Okay, let's start, and it should be done simultaneously on both the sides. Okay. I got dullness. Okay, so now I'll do on mid axillary line on fourth intercostal space. Fourth, then here fifth, then sixth, then seventh. On eighth, I am getting dullness. So done mid clavicular and mid axillary. Even in mid axillary, we have to do actually simultaneously. Okay. Here third intercostal space, then you have to do here, then again fourth here, then here, fifth here, then again here, in that way. Okay. Now we will see posteriorly. Okay, mid scapular line, even posteriorly we will see. Okay. On 11th intercostal space, we will get dullness. So, by doing this, we get to know the borders of lung. So, now for apex of lung. Okay. For apex of lung, we have to ask a person to see on opposite side. For example, I am doing for the right side apex. So, I have to ask a person to see on left side, and then I have to percuss on supraclavicular fossa. This is a clavicle, above that there is supraclavicular fossa. Now I have to percuss. So it will be resonant. Once again, this is clavicle, above that supraclavicular. Okay, this is resonant. Now when I am checking for the left side apex, I have to ask a person to see on right side. Okay, and then again I have to percuss. So this is resonant.
Now when we are doing percussion for the posterior aspect, so that time we have to ask a subject to keep his both the upper limb in crossed position over the shoulder, and then we have to do percussion on posterior side. In the next slide, importance of notes. Okay, so now resonant is normally in normal lung. So when the patient is not having anything, right, when the lungs are normal, we will get to see resonant sound. Now when the resonance has been increased, means it has become hyper resonant, that means there can be pneumothorax, COPD, or maybe the cavity, large cavity. It can be a tuberculosis. Then dull note is seen in case of consolidation, which is seen in pneumonia. Then fibrosis, collapse, thickened pleura, we get to see dull note. And stony dullness is seen, or absence of sound. Okay, we don't get any sound on percussion. So that is on pleural effusion. Okay, so these are the importance of notes. Normally it is resonant. Okay, and whenever there is air, AIR, R for resonance, and in solid D, right? A solid at the end it is D letter, so D for dullness. This is how also you can remember. Now let's see auscultation. So auscultation we have to do, we have to check for breath sound, and then we have to check for vocal resonance. Okay, so breath sounds are vesicular breath sounds, bronchial breath sounds, and bronchovesicular breath sounds. So we'll see in detail about this. And abnormal sounds, these are seen in pathological condition, not in normal subject. So those are rhonchi, wheeze, stridor, crackles. Okay. Now, which are the areas where we will auscultate? Okay, for the breath sounds. So those are supraclavicular, infraclavicular, mammary, inframammary, axillary, infraaxillary, suprascapular, interscapular and infrascapular. I have shown all these areas in the next pictures. Let's see. So this is memory area. Doctor is auscultating. This is suprascapular area. Okay. Then this is interscapular area. Then here doctor is auscultating on trachea. So for the bronchial breath sounds, we have to auscultate on trachea. And for vesicular breath sounds, we have to auscultate on periphery of lung. So bronchial breath sounds on trachea and vesicular breath sounds on periphery of lung. And this is on infrascapular area. Here actually triangle of auscultation is present where we get to hear best breath sound. Okay, so triangle of auscultation is this, okay, which is medially bound by trapezius, then inferiorly by latissimus dorsi muscle, and then laterally by the scapula. Okay, so this is triangle of auscultation. So here you can see in the lower part of scapula, we have a triangle of auscultation. So here the doctor is auscultating on triangle of auscultation, and there on posterior side of chest, best breath sounds we can hear nicely. Okay, let's see in the next slide. Vesicular breath sounds. So these are the breath sounds gets originated in the large airways, and it is heard all over the lung tissue except over the trachea. So vesicular breath sounds should be heard on periphery of lung. Presence of vesicular and bronchial breath sounds in normal subject is normal, right? But the location of these sounds are important. That is, vesicular breath sounds are heard on periphery, okay, but the bronchial breath sounds are heard on trachea. So this is vesicular breath sounds which is heard on periphery, okay, all over the lung tissue. The sound is low pitched, rustling sound. Here inspiration. A sound on inspiration is longer and louder than on expiration, and there is no gap between that. You can see here. So this is inspiration and this is expiration. So inspiration is longer than expiration. Okay, and there is no gap between inspiratory and expiratory sound. After this auscultation, in the last slide, I have put a video where you can hear. I have put a video where you can easily hear the vesicular, bronchial and other abnormal sounds. We will see in the next slides, coming slides. So this is about vesicular breath sounds. Okay. Next is bronchial breath sounds. These are originated by the movements of air in trachea and large bronchi. It is best heard over the trachea, adjoining manubrium and upper sternum. It is high pitched blowing sounds, and expiration is more, means it is longer and louder than inspiration. Expiration is longer and louder than inspiration and with the gap. So you can see here, this is inspiration and this is expiration. Okay, and there is a gap. So in vesicular, inspiration was longer, whereas in bronchial, the expiration is longer. And in vesicular, there is no gap between inspiration expiration sound. Here in bronchial, there is a gap. And bronchial is best heard over the trachea, whereas vesicular over the periphery. Bronchovesicular breath sounds. Here inspiration and expiration are equal and no pause. Found in early cases of consolidation and partial collapse of lung. Now let's see how to check for breath sounds. Okay. Checking on trachea for bronchial breath sound. Then on periphery for vesicular breath sounds. Ask a person to inspire and expire so that more clearly we can hear. checking for a triangle of auscultation. Now, this is a video where we will see all breath sounds. Okay. Now, vocal resonance. This is also second thing which we do on auscultation. So what is vocal resonance? It is nothing but it is auscultatory counterpart of vocal fremitus, and it indicates the conductivity of lung. Now, what is the difference between tactile vocal fremitus and uh, vocal resonance? So tactile vocal fremitus is palpatory finding, whereas vocal resonance is auscultatory finding, right? So in tactile vocal fremitus, we are using ulnar border of palm. Here we are using stethoscope, okay, to hear for vibration, okay.
One, two, three. 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 One, two, three.
Now when it is increased in pneumonia, in tuberculosis, and it is decreased in case of pleural effusion, pneumothorax, and collapse, okay, and thickened pleura, emphysema. Next, few terms are there. What is eupnea? It is normal quiet breathing, okay, so where respiratory rate will be 12 to 18 per minute. What is apnea? So that is, it is complete absence or cessation of breathing. What is dyspnea? It is difficulty in breathing. Hyperpnea is increased rate as well as depth of respiration, okay. Tachypnea is increased rate of respiration which is more than 25, okay. And hyperpnea is hypercapnia, that is increased carbon dioxide level in the blood. So these are the few terms, okay. So we should know what does the mean, okay. Next, this is a table I have just put that few clinical condition which routinely comes in hospital, okay. That pneumonia, COPD, pleural effusion, these are the cases routinely we get to see in medicine OPD and medicine wards, okay. So what happens in this condition? You might get a question that why are we actually doing respiratory system examination? So basically to get a differential diagnosis, and okay, so we have to do the respiratory system examination. See, when a patient is having pneumonia, so in that patient the chest movement will decrease, okay. Or on percussion of chest we will get dull note. Tactile vocal fremitus would have been increased, and auscultation, on auscultation actually, as I said, on periphery of lung we will get uh, vesicular breath sound, but here you get bronchial breath sound, okay. And in vocal resonance is increased in pneumonia. In COPD the chest movement decreases, percussion will be hyperresonance, tactile vocal fremitus will decrease, auscultation we get crackles, and vocal resonance will decrease. Pleural effusion, again chest movement will decrease, percussion stony dull note, tactile vocal fremitus will decrease, auscultation diminished breath sound you get to hear, and vocal resonance will decrease. Thank you.